Thank you very much, Paul. Thank you, Dr. Bunn. That was a fantastic talk, and I'll be talking in similar vein today. And just wanted to thank Dr. Heidi Nicol and Emerge Australia for organising a fantastic conference and for inviting me to speak today as well. So I'm going to talk about our team's research setup at the Royal Children's Hospital and our recent longitudinal MRI studies into this search for a diagnostic brain biomarker, and we're focusing on paediatric CFS. So the Murdoch Children's Research Institute sits within the Royal Children's Hospital, and we are lucky enough to have state-of-the-art facilities in terms of a research MRI scanner, and I also put up some nice fairy friends that we have in a special zoo enclosure at the hospital, which I can assure you is as much fun for the staff as it is for the children who are at the hospital. More importantly, our research team is aligned with the Royal Children's Hospital CFS Rehabilitation Clinic, and that's run through the Victorian Paediatric Rehabilitation Service, or VPRS. And we recruit patients from this clinic into our research studies. The team pictured here uses a multidisciplinary rehabilitation approach, and it consists of paediatricians, some of who are in the audience with us today, Dr. Kathy Rose, many of you would know, and it also includes physiotherapists, occupational therapists, a clinical psychologist, and an educational support teacher as well. And our core research team over the left here, Dr. Sarah Knight, is a team leader for the Neurodisability and Rehabilitation team at MCRI. Dr. Mark Seal is the head of developmental imaging for MRI at MCRI. Dr. Adam Scheinberg is the statewide medical director for the VPRS, and myself, who manages the CFS research program there. So you would all be familiar with these criteria. The Royal Children's Hospital CFS Rehab Clinic works with children and adolescents using Leonard Jason's paediatric case definition, and that's based on the Canadian consensus criteria. One of the main differences is this last criterion here: the unrelenting fatigue has to persist for at least 3 months, which is different to adults, where it's 6 months. We know that adolescents, and particularly between the ages of 10 and 19 years of age, represents one of 2 age peaks in the incidence for CFS. And we know that when it occurs in adolescence, it's really occurring at a significant time of development in terms of brain maturation, forming social relationships, educational attainment, academic skills. So it really has a big impact on children's lives, can result in this significant reduction in functioning and have a big impact educationally and socially as well. While we know that prognosis is generally better when illness onset occurs in adolescence compared to adulthood, we still lack this elusive diagnostic biomarker for the condition, and that really makes it difficult for clinicians to differentiate the hallmark symptoms of fatigue from other illnesses. And research for a diagnostic brain biomarker is leading us in this direction towards the brain. So there's been increasing support, as Dr. Bundan alluded to, support for this notion that disruption to normal brain function may underlie many of the core symptoms, including fatigue, pain, sleep, and cognitive dysfunction. And the typical cognitive dysfunction we see is usually that slowed processing speed of information, deficits in sustained attention, and a working memory disturbance. And in adults, there's mounting evidence that neuroinflammatory processes, as we've heard a bit about today, may represent a pathophysiological mechanism of CFS, and that's through evidence of structural and functional brain abnormalities on MRI in comparison with healthy adults. And one of the methods used is resting state functional MRI, which we've heard about already, so I'll only produce a short summary, but you've heard from Dr. Bunn, it was a fantastic explanation. It can measure spontaneous neuronal activity when the individual is not engaged in a specific cognitive task. That's why we call this one resting state, a functional MRI. And functional connectivity across the brain can be interrogated by examining spontaneous synchronous activity. So 2 brain regions are thought to be functionally connected if they show highly synchronous activity. So in this way, we can investigate the connectivity within or between specific regions of the brain or networks of the brain when a person is in a sort of passive mental state, lacking cognitive effort. And we might call this a kind of standby mode of the brain. So the default mode network, or the DMN, is one such network which has been shown to become activated during periods of rest and decreases activity with attentionally demanding tasks or cognitive effort. Importantly, research has shown that adults with CFS may show abnormal intrinsic functional connectivity within the DMN in the medial prefrontal regions, parietal regions and posterior cingulate, and that this disruption may relate to CFS symptomatology and CFS severity as well. Although results vary and others have shown that connectivity between certain regions is comparable to healthy adults. So what's difficult at the moment is that we still lack a clear and consistent characterisation of brain functioning abnormalities in this condition, although it seems like we're working towards it. And one big issue for our team is we don't know how well the data from adults translates to children. And there are a few reasons for this. So firstly, there's just such limited objective data in adolescents in all areas. But of the MRI research, there's really only a handful, literally about less than 5 studies in adolescents looking at brain structure or brain function. And that makes it difficult for us to determine what we should be expecting in the adolescent CFS brain. The adolescent brain is in a different developmental stage in adolescence, and so the brain behaviour relationships we see and the networks and the cognitive functions, they're still coming online, they're still emerging, and they're not yet fully established. So it makes that sort of direct comparison from adults to adolescents really difficult. It's also difficult to predict that pattern because, as I said, we don't have this sort of typical pattern in adults that we know yet. And we're still learning about this relationship between cognitive function and fatigue and structural and functional brain impairments. So again, it makes that prediction difficult. So our research team was interested in investigating whether paediatric CFS actually has a differential effect on resting state functional connectivity in the brain in terms of cognitive functioning and fatigue in comparison with healthy adolescents. And really the feasibility of eliciting and mapping fatigue and this sort of post-exertional malaise in the brain. So we wanted to look at the long-term effects of mental effort or cognitive exertion in adolescents diagnosed with CFS compared with healthy controls. And specifically, we wanted to characterise changes in connectivity, cognition and fatigue. We wanted to determine whether the groups differ in their rate of change over time. And finally, we wanted to see whether there were brain behaviour relationships present. So we actually performed this study twice, once when the CFS adolescents were first diagnosed, and then we did a follow-up about 2 years later. So in the first study, we had 48 participants, 25 in the CFS group and 23 controls, and they ranged between 13 and 18 years of age. And at follow-up, we had 34 return, now between 15 and 21 years of age. As I said earlier, our patients are recruited from the specialised clinic at the Royal Children's Hospital, and we recruited our healthy controls through advertising posters around the hospital clinics. And all people needed to have sufficient English to complete the assessment and questionnaires, no history of psychosis or bipolar disorder, no pre-existing developmental disability or brain injury, and no use of any current medication that may affect brain functioning, so things like methylphenidate, for instance. We used a range of measures in our study, so the measures are listed on the left here, hopefully you can see them. We had to choose measures that were valid to be tested over multiple time points. So we used a subjective self-report of the visual analogue scale for fatigue severity. We used a computerised battery for cognition, looking at processing speed, sustained attention, working memory and new learning. We used a multi-million-dollar 3T scanner with a multi-band resting state bold sequence, standardised neuropsychological tests to assess academic achievement and intellectual functioning. And then we looked at a range of other characteristics such as mood and sleep quality and fatigue-related quality of life, as well as a few illness characteristics as well. So we were able to really well characterise this sample. This is the procedure, and I'll go through. It was tough going for all participants in our study, but especially the children with CFS. So first they're put into the MRI scanner. It takes about 45 minutes. We're just focusing on the functional MRI data today. But as soon as they came out of that MRI scan, we gave them a computerised battery assessing their cognition. As soon as they finished that, this is what we call the mental exertion period. So this is supposed to mimic like a period at school where they undertake some reading, some maths, some spelling, really working their brain hard. And as soon as they finish that, we then assess their cognition again. And then we give them a short intellectual functioning assessment, and then they go straight back into the MRI scanner. So this is no breaks, this is straight through. Probably most people in this room would find this a bit tough as well. So we're very, very grateful to the participants in this study. And we also assessed their fatigue severity before and after this exertion period to see how they were feeling. So for the methods, or the statistics, for resting state fMRI, we extracted intrinsic connectivity networks using group independent components analysis, or ICA, and we identified 10 networks according to Smith and colleagues. They were 3 visual networks, 2 frontoparietal, an auditory, a sensory motor network, an executive control network, and we found 2 components that identified as the default mode network, and I'm happy to go into details about that later if people are interested. Subject-specific spatial maps were computed for each component using a dual regression approach, and we saved them for later voxel-wise and network analysis. So the voxel-wise analysis, we were looking at intrinsic connectivity within each of the ICA components identified. We started with the DMN, the default mode network, as that was our interest based on previous literature, and then we looked at all the other networks as well. And the inference was performed via a general linear model with group and time entered as independent variables and sex and age as nuisance variables. We also then performed a network-level component-to-component analysis, and this was looking at the connectivity between each of the components identified. And we used a similar general linear model for the connectivity matrices there. So now I'll go on to present some sample characteristics. This is of the samples at diagnosis. So we can continue recording for this, and I'll tell you when to stop the broadcast because these results have not yet published. They're currently under review, but we can show this data. So I've got a series of tables here, and instead of showing you just all these tables, I've just summarised it to show you where the differences were and where the similarities were between groups. So the CFS group were similar to healthy controls in terms of their age, their female gender, so there was a greater proportion of females, but that was the case in both groups. And we know there's a greater proportion of females in the CFS population as well. They were well matched on socioeconomic status, their intellectual functioning, academic achievement, sleep hygiene, depression, anxiety levels. But the CFS adolescent group were different to controls in that they missed a greater proportion of school in the last term, which is perhaps unsurprising given what we know clinically about this group. They were reporting poorer sleep quality overall, and we use the PEDS-QL, which looks at fatigue-related quality of life, And this CFS group were reporting poorer general fatigue, sleep rest fatigue, and cognitive fatigue. So really all aspects of fatigue they were reporting as much higher than the control group. When we follow them up about 2 years, we see, again, they're very similar, very well matched on most variables. But again, the CFS group is still, even 2 years later, reporting that they're feeling much greater fatigue in all these areas. And then just a little bit of an odd finding in that their spelling was a little bit worse. So now I might ask that the live broadcast be turned off, unfortunately, but we'll check back in soon, just because these results are currently under review. And we think this will be really important for clinicians, but particularly school staff, to consider when we assess this patient group. And as a clinician, I'm always interested in evidence-based strategies to help with cognition. So we would suggest, this is what's been suggested in the literature and clinically as well, helping students really maintain and sustain their attention in the work environment and getting the school staff to help with this. Really slowing the pace of information for those that can become easily overwhelmed and overloaded with information. And we use what we call chunking, basically breaking up information into more manageable components so it's not too overloading. And to help with memory as well, providing verbal prompts and visual prompts together to help that memory load. Thank you very much for the funding we've received, and really, really grateful to the families involved in our research. Thank you.
Thanks very much. Questions?
Thank you, Elisha. That was a very interesting presentation and great to see such a detailed study. I've got 2 queries about it. One, the size of the group on follow-up after 2 years was smaller, and did that represent a bigger dropout amongst the patients who had the ME/CFS? And secondly, this has all been done on averages, and as some of those patients may well have recovered quite well during that 2 years, have you somehow accounted for that by looking at individual results?
I'll start with the second question because that's fresher in my mind. As a part of this study, I haven't presented the results today, but we actually asked, we gave the CFS group at follow-up a specific questionnaire that was designed based on the Canadian consensus criteria for the symptoms. And we asked them to tick off. So it was put sort of as a plain language statement, which we normally, in research, plain language statements are put at the reading level ability of an 8-year-old, I think. So all of the symptoms were reworded. So it was something that children, adolescents, although a lot of them were adults by this stage, and we got them to tick off and endorse which ones they were currently experiencing. I think from memory, there were about 3 to 4 participants in that 17 group who reported according to those criteria that they had recovered. I should mention at the end of that questionnaire, we just had one question that says, do you think you've recovered? Do you still have CFS? So there were 3 or 4 people who said, no, I don't have it anymore. But there was some variation in what was being reported. So this is anecdotal. I noticed that some people who said they no longer had it were still reporting that they had the hallmark features of fatigue, and vice versa. There were some saying, I don't have fatigue anymore. Do I still have CFS? Yes. So it's really interesting data, and we haven't looked at that yet, but it's interesting to see what people think and which symptoms they're actually endorsing. So your first question was about the sample size. So we had 48 to begin with and 34. So I don't think there was a huge... The groups were fairly well matched in number, 25 and 23 to begin with, so it was a fairly equal attrition rate, I guess, over time. Most of those were because people had moved away, moved interstate, so they couldn't make the trip back. We didn't have the funds to support them to come back, but they couldn't come back to have the MRI scan here. That was the case in most. And I think one person said that their child no longer had CFS, they had Lyme disease instead, so they changed their diagnosis and they no longer wanted to be involved in the study, but the rest were because they moved away.
Yeah. Any other questions? Yes, I thought there was one. it seemed that all of the default mode network connections were in the higher brain. Are there connections to the midbrain that are considered part of the default mode network?
I don't think so, but there's multiple networks in the brain. So there's ones that include lower parts. This is more, it's more frontal and parietal regions that are traditionally involved in the default mode network. But I think there's so much, Dr. Barnes' work is so exciting, and I think there's a lot of future potential there to look at subcortical structures and how they're involved in cognition, but also involved in this illness as well.
Thank you.
Yeah.
Just interestingly, was there any findings with respect to anxiety scores, depression scores with your CFS group in the adolescents and your findings here?
They were really well matched. So we looked at standardised measures of anxiety and depression in both groups, and both groups were showing, on average, they were very well matched. There were some both in the control group and there was a range, obviously, so some were falling in clinical ranges in both of those groups, but on average, they were well matched and falling in a non-clinical range.
Okay, we'll cut the session, end the session there. We're spot on time though, perfectly done. Elisha doesn't get to have a break.
No, I will chair the next session. Thank you, Paul. So we are,
First of all, we should
yes.
thank the